We started our first trial. This is the first human trial in our refractory or relapsed TAL by using donor-derived CD7 CAR T-cell therapy. And we first, in the preclinical study, we used the intra-block technique to retain the CD7 molecules in the cells, in the endoplasmic reticulum. So when we culture the CAR T-cells, this CAR T-cell doesn't express CD7 anymore. So we can prevent this CAR T-cell fratricide in the preclinical study. And then we conduct second generation CAR using lentivirus and the co-stimulatory domain is 4-1BB. And then we conduct phase 1 trial. The phase 1 trial, and we screened 27 patients, and 20 patients enrolled in our trial, and all 20 patients had received CD7 CAR T-cells. Firstly, all the patients involved in our trial had received the donor-derived CAR T-cells and not the autologous CAR T-cells. So for the post-transplantation patients, we use transplantation donor T-cells for manufacture of CAR T-cells. But for the patients who relapse or refractory to chemotherapy, they didn't receive transplantation. We used the new donor T-cells for manufacturing CAR T-cells. So we had 8 patients to receive the new donor CAR T-cells. The new donor CD7 CAR T-cells. And after receiving CAR T-cells, all the patients development cytokine release syndrome. And luckily, only 2 patients had severe CIS. So most of the patients had developed a mild CIS in our trial. And then for neurotoxicity, we found only 20 patients had a neurotoxicity and mild and reversible. So the neurotoxicity is not severe. But in our study, we found that there's 2 adverse events is very important. One is the graft-versus-host disease is GvHD. And we had 16% of patients had development GvHD, but most of them had a mild GvHD because it's the donor-derived CAR T-cell. So it's an allergenic CAR T-cell. So the GvHD is very common in our trial. But the severe GvHD is not common in our trial. So most of the patients can reverse the GvHD by steroids and looks literally. So all the patients had controlled their GvHD within 45 days. And the other one is the cytopenia. In my opinion, the cytopenia is very important adverse events in our study. However, 18% patients had severe cytopenia before enrollment. But all the patients had developed a severe cytopenia during the study. And we found the patients who received the new donor-derived CAR T-cells need to bridge to transplantation to relieve their cytopenia. But for patients who had received the post-transplantation donor-derived CAR T-cells, these kind of patients can recover from the cytopenia within 3 months. The safety profile of this phase 1 trial, we think is maybe severe, but it's manageable. On the other hand, we think the efficacy is promising because for 20 patients who had enrolled and infused our donor-derived CAR T-cells, 95% patients had over response for this kind of therapy, and 19% of patients had achieved MRD negative, include had a extramedullary disease involvement. So the efficacy is promising for this study. And for the long-term survivor profile, we found 7 patients had bridge to transplantation, and 6 patients had remain in remission. And in the patients, in 11 patients who had not received any anti-leukemia drugs. And these kind of patients can be followed for in the median time of the 6 months. And the only 1 patient had relapsed with CD7 negative, and 1 patient had died of the pulmonary infection. So most of the patients had a very good long-term survival in our study. We think the least high efficacy was conducted by our good expansion of CD7 CAR T-cells in their peripheral blood and the bone marrow and the and other such as CSF. So we detect their CAR T-cell expansion in the long-term survival. We found for the patient who had more than 6 months survival time, this kind of patient had a very good expansion of the CAR T-cells in their peripheral blood. So we think the patients can keep the in remission status because of the good expansion of the CAR T-cells. And then we focus on the T-cell immunodeficiency because when they receive the CD7 CAR T-cells, the normal CD7 T-cells and NK cell were developing, and we found the CD7 negative T-cell increased within 3 months. So we found the amount of the CD7 negative T cells and NK cells can increase to the normal level. And then we detect the function in vitro. We do the anisopod and do some experiments to detect the CD7 negative T cell and to test them to action with the Candida fungus or with the CMV and EBV virus. So we found some evidence of the CD7 negative T cell had a normal function. So that's all the result of our study. However, we think this is a small cohort in our study, and the follow-up time is not long. So we think we can keep on to follow up these patients and find whether this therapy can benefit the TAL patients.